Okay, hi everyone. My name is Dr. Rama Kastury. I am an OBGYN and medical geneticist. So today we are going to be talking about prenatal genetic testing um, and for X and Y variations and what these tests mean. Um, I'm gonna give a nice little overview of, the scope of prenatal genetic testing as it is right now. So our objectives today are to just review, what are chromosomes, what is genetic testing, what are genetic disorders, and then I am going to touch upon prenatal genetic screening, and then follow with prenatal genetic diagnostic testing and talk about the difference between the two, and then give a nice little overview at the end. So what is prenatal genetic testing? Prenatal genetic testing gives parents-to-be information about whether their fetus has certain genetic disorders. And I know that sounds very broad and vague, but I wanted to start off nice and broad and slowly work our way, deeper, more specific. So when we talk about, genetic testing and genes and genetic material, I like to just give a nice little overview about, what are genes, what is, how do our, how does all of this come into play? So we will start just with a broad view of our genetic material. So this is just a picture of our chromosomes. And so we have 23 pairs of chromosomes in every cell in our body. They are numbered from chromosome 1 to chromosome 22. And this 23rd pair of chromosomes is our sex chromosomes. And so this is, the focus of this talk is, focusing more so on sex chromosomes, but I like to just give a nice, general overview of the scope of all of our chromosomes as it, pertains to a few slides in what I talk about. So, when we're looking at our chromosomes, this is a nice little zoomed in view of a chromosome. And so a chromosome is basically, a string of letters of DNA that are tightly wound up to make this rod-like structure. And so if you unwind this chromosome, this demonstrates just a nice zoomed in view of our DNA. And our DNA consists of multiple combinations of 4 letters, A, T, C, and G, which is shown here. And when you think about DNA, I like to use an example of, our entire genome, which means all of our genetic material, is, exists in a textbook, for example. And so our textbook has 23 chapters. And so we like to think of a chapter as a chromosome. And so each chapter makes up, their own little chromosome. And then a sentence equals a gene. So that's a nice little overview to just kind of, break things down from, in terms of a structural view of our genetic material. So what are genetic disorders? And so genetic disorders are caused by changes or variants in a person's genes or chromosomes. And so today's talk is mostly focusing on chromosomal changes and chromosomal disorders, and variations in sex chromosomes that can occur. And so when we talk about changes in the number of chromosomes that are supposed to be there, we use terminology like aneuploidy, which means that there is either someone's missing a chromosome or there's an extra set of chromosomes. And if you look back at our little karyotype, each chromosome has 2 copies, usually one from our mom and one from our dad. And so when there's a change in that, when a person has more than 2 copies where they have 3 copies, or if they're missing an entire copy, that general concept is called aneuploidy. And so we use the term trisomy to explain that there's an extra chromosome. And so with an extra chromosome, there would be 3 copies. And we use the term monosomy to say that we're missing a copy. And so there's only 1 copy of a particular chromosome. Single gene disorders are caused by changes in specific genes, or where there could be a small little spelling mistake or a spelling change in a gene. And so that's, when that occurs when you zoom in really, really far into a chromosome and you notice that there's 1 letter missing, or there's maybe a small sentence that's deleted in the book. And just a couple of examples of single gene disorders are sickle cell disease, cystic fibrosis, Tay-Sachs, and many other. And by the way, interestingly enough, on all of our chromosomes, we have about 20 to 30,000 genes. And so you can imagine how many different combinations of things can go wrong and can lead to various numbers of conditions. So just a quick little look at, the incidence of X and Y variations. And so this is just very general data that we like to, use. And so, variations in X and Y, the X and Y chromosome can lead to, for example, one common condition is Turner syndrome, where someone is missing that second sex chromosome. So they're either missing the second X chromosome, or they're missing their Y chromosome. And so in Turner syndrome, that incidence is about 1 in 3,000. In trisomy X syndrome, someone has an extra X chromosome. And so that is, the incidence of that is about 1 in 1,000. Same with Klinefelter syndrome, where someone has 2 X chromosomes and an extra Y, or an X and a Y and an extra X. That's about the same as trisomy X syndrome. It's about 1 in 1,000. And then there's 47XYY syndrome. That incidence is about 1 in 1,500. Okay, so focusing on prenatal genetic testing, what are the different types of genetics tests that are, and just general tests that are available for a patient who's pregnant, that's, trying to understand their risk of a genetic disorder. So there's 2 types of tests. So we like to really break down the general prenatal genetic tests down into 2 major types. So the first type is screening tests. And so screening tests give you a general understanding of risk towards a certain condition, but it does not tell you a definitive diagnosis. And so, these tests tell you the chance that your fetus or your baby might have an aneuploidy or some other disorder, but it's not definitively diagnosing your baby with Turner syndrome or Klinefelter. And so it often can be very confusing to navigate all the different tests when you're pregnant, and, understand which one is a screening test and which one is a diagnostic test. So, prenatal diagnostic testing, and I'll go into detail with all of these tests. Prenatal diagnostic testing usually tends to be invasive testing, and we use the word invasive to mean that there is some sort of a procedure that may be involved where we need to take a sample of the pregnancy or cells of the baby in order to get a more definitive answer. And so diagnostic tests give us a diagnosis. And so it tells us with pretty high certainty whether the baby has a specific disorder or not. Okay, and so one of the first screening tests, which this next section I'll focus on, is all screening tests. So one interesting screening test is called carrier screening. And so carrier screening can be done either before you get pregnant or while you're pregnant, if you didn't have time to really think about and overanalyze what kind of genetic testing you wanted to do, and you got pregnant, and we end up usually doing carrier screening at that time during pregnancy. And so carrier screening looks at a couple's risk of being a carrier, both of them being carriers for specific autosomal recessive conditions. And it's done on parents using either a blood sample, or sometimes we can do it with a cheek swab, or a small tissue sample from swabbing the inside of the cheek. And these tests are, like I said, used to evaluate whether a person carries a specific mutation in a gene, and if that's the case, then we usually test the partner to see if they carry a similar mutation in the gene. And if they both are carriers, then there's a risk that the baby may have the specific condition. And so this is used for autosomal recessive conditions. Okay, now looking at the other specific tests that are done only during pregnancy, I'd like to focus on the ones that I've bolded here, and the tests in general that are available that are considered prenatal screening tests are first trimester screening, second trimester screen, which includes the quad screen, which you may have heard about, nuchal translucency, and then sequential screen and integrated screen. And then last but not least, our favorite, cell-free DNA testing. So I'm going to focus on the first trimester, second trimester screen, nuchal translucency, and cell-free DNA. In general, these screening tests are testing pregnant women's blood, in the first and second trimester, and additionally adding on an ultrasound exam to look at specific markers on ultrasound. And they look for aneuploidy. They can also look for neural tube defects and certain defects of the abdomen or the belly, the heart, and the facial features and other organs. So looking at the first trimester screen, it's usually done between 11 and 14 weeks, and that can vary based on your practice and your doctor's preference. So the first trimester screen looks at blood work that includes the free beta HCG and a marker called PAP-A, which stands for pregnancy-associated plasma protein A. So these are both from the mom's blood. And then we combine that with an ultrasound, looking at the nuchal translucency. So this is an ultrasound on your belly that looks at a small fold of skin at the neck of the baby. And it's performed around 10 to 14 weeks gestation. And abnormal measurements of that nuchal translucency can show an increased risk of certain chromosomal abnormalities like Down syndrome or monosomy X, which is also called Turner syndrome. And sometimes, it can be linked to, other physical defects of the heart, the abdominal wall, and the skeleton. It can sometimes be associated with a condition called Noonan syndrome, which is a single gene mutation, a single gene disorder, not a chromosomal disorder. So this is just a nice little picture showing us what that nuchal translucency looks like. So it's a side view. Sometimes it can be really tough to get a nice look at the baby's, nuchal translucency based on the position of the baby. If the baby is wiggling around and moving a lot, which they tend to do at this gestational age, it can be a little bit hard to pinpoint that nuchal translucency. So if your doctor can't get it that one time, right then and there, they might have you come back and try and look at it again. Another ultrasound marker that we use is the nasal bone. And so sometimes, when that is absent, that can be a small marker that could make your doctor raise an eyebrow that you would have a slightly increased risk of Down syndrome as well. So we use all of these markers to formulate a number that looks at your overall risk for a chromosomal condition or a chromosomal abnormality. Again, this is another picture of the nuchal translucency. Just wanted to show a normal nuchal translucency here. And then this is just an example of a increased or thickened nuchal translucency. Okay, so moving on to the second trimester, usually the second trimester screening includes the quad screen and an ultrasound. The quad screen, it basically looks at 4 markers similarly to the blood work that we said in the first trimester screen. And it basically looks at your risk of chromosomal abnormality, either Down syndrome, trisomy 18, trisomy 13, also neural tube defects. And then ultrasound, same thing. We do an ultrasound between 18 and 22 weeks of pregnancy just to look for major physical abnormalities that could be going on in the baby's organs. So sometimes we combine the first and second trimester, or first and second screen, and that could be the integrated or the sequential screen. Not a lot of people, some people still use, definitely do this. The integrated screen basically says, at the end of both of the first and second trimester screen, we have all the data, we formulate our risks, and then we give it to you. The sequential, like in the name, it's sequentially done. So now moving on to cell-free DNA. Cell-free DNA basically looks at small particles of the baby's DNA that float around in the mom's blood. These small particles usually make up 2 to 10% of, the total cell-free DNA in the mom's blood itself. It mainly comes from the placenta, which is really important to know. Sometimes, you can have a slightly abnormal result on cell-free DNA, and then your baby's born and you test the baby, or you confirm with amniocentesis or CVS and it's normal. And so sometimes that placenta, there can be placental mosaicism, which can cause a false positive result. And then, interestingly enough, after the baby's born, the baby's fetal DNA actually clears from the mom's blood within hours after birth. Initially, this was proposed for patients with that were high-risk patients, or patients advanced maternal age, greater than age 35. But nowadays, it's offered to people even at younger ages and low-risk moms. There is a very low failure rate. Sometimes when we do, the cell-free DNA, there could be not enough percentage of fetal DNA. And so that's called a low fetal fraction. Usually it's less than 4%. So sometimes in that case, we would repeat the tests again, just to see if we can get enough of the baby's DNA to do the test. So cell-free DNA, this shows just a nice little diagram of this is the placenta right here. And then we have these trophoblast cells that break down, and they can, get transferred into the mom's blood. And they are these little red DNA fragments that float around in the mom's blood. And so the placenta and the mom's blood are in contact, and they're constantly communicating back and forth. And so that's how that crossover happens. So quick little look at positive predictive value for sex chromosome variations in cell-free DNA. The positive predictive value is for these is actually quite low. Initially, a lot of this prenatal genetic screening testing was done to really, was focused on looking at a mom's risk of carrying a baby with Down syndrome. Down syndrome is when you have a third copy of chromosome 21. And so, it wasn't initially, all of this wasn't initially made, with sex chromosomes in mind. But as we've learned more and more about different variations that can occur with our chromosomes, sex chromosome variations we now know that they happen quite frequently. And so, unfortunately, the testing it's not as high as the positive predictive value for looking for Down syndrome and, trisomy 18. And just to review, the positive predictive value is the probability that people with a positive screening test actually truly have that condition. So if you have a cell-free DNA test and it screens positive, make sure and look at those, positive predictive values. And then, by the way, just wanted to kind of go over terminology real quick. Cell-free DNA is called many different things at many different centers. And so some people call it cell-free DNA, some people call it NIPT, which is non-invasive prenatal genetic testing, or non-invasive prenatal screening, NIPS, cfDNA, or free fetal DNA. Those are all just different terms for the same exact thing. And this test is done by a blood draw from the mom's blood. And so that's why we call it non-invasive prenatal testing, is that, we're not sticking a needle in the belly like amniocentesis and CVS. It's just a quick blood draw. Okay, so moving on, this is just a quick little sample normal report for cell-free DNA, a low risk report. And so as you can see, I mentioned we, focus so much on trisomy 21, 18, and 13, but we do also get information about the sex chromosomes. So each lab reports things a little differently. So this lab, they just happen to report the sex chromosomes as either male or female. This lab actually reports the sex chromosomes as also male, but then they specify results consistent with two sex chromosomes, X and Y. And then they do also mention, the positive predictive values and in more detail as you flip through the report. So a quick little case. We have a 30-year-old G1P0 female who had NIPS, or cell-free DNA testing, at 13 weeks. The results showed that it was a male fetus with low risk for trisomy 21, 18, and 13, monosomy X, and triploidy or vanishing twin. So basically a low risk screen and normal testing. She declined doing an anatomy scan or an early scan at 18 to 20 weeks. And that NIPT testing did give gender. And then, she did have an early scan just to determine her due date. So fast forward, at 30 weeks gestation, she had an anatomy screen ultrasound that looked at, all the different organ systems and noted bilateral clubbed feet, clinodactyly, so curving of one of the fingers. In this baby, it was the left pinky, micropenis, so the penis size was a little small, echogenic bowel and fetal growth restriction, meaning the baby was just growing a little on the small side. And so this is just an example of what the testing showed. So she had 49XXXXY. And so, sometimes with a negative, screen, sometimes we can still find a small abnormality in a sex chromosome abnormality. And so typically what they're looking for in cell-free DNA is they're looking for two different chromosomes, X and Y. And so, sometimes nowadays with technology, they are, able to detect that a little bit better. And sometimes that might pop up as, just some abnormality was found, and that you would need to do additional, more diagnostic testing. And so I will transfer into and move into that diagnostic testing aspect of things. So focusing on, diagnostic testing, we typically it is done by either CVS or amniocentesis. And so, because it is invasive testing, we need to obtain a sample of the baby's cells from somewhere. So either, that can be either directly from the placenta, which is CVS, or the fluid around the baby. And unfortunately, or fortunately, depending on how you look at it, with both CVS and amniocentesis, it is a little procedure where it is a needle either through the belly or through the cervix. So, so we'll talk about CVS. CVS is done typically between 10 weeks and 13 weeks and 6 days. We usually like to do it closer to that, 12 to 13 weeks stage. We try not to do it too early, and we try not to do it too late. It can be done either transabdominally, meaning a needle through the belly, or a transcervical approach, depending on the location of the placenta. And risk of miscarriage is in a non-twin pregnancy, and just a one singleton pregnancy is about 1 out of 300 to 1 out of 500. This data is a little old about the risk of miscarriage. And so newer data shows that this risk is actually lower if the CVS is being done by an experienced MFM provider. And the risk may be higher if you have multi-gestation pregnancy where you have twins or triplets. So just a quick little picture of transcervical approach for CVS. We have the ultrasound probe showing us the image, and then we have a small biopsy catheter. And so this is the entrance to the vaginal canal. This is your uterus. This is the baby and the pregnancy, and this is your placenta. And as you can see, we're putting a small little catheter into the placenta to get a small biopsy. With transabdominal CVS, in this case, the placenta is on the top of the pregnancy, closer to your belly and easier to access, so anterior placenta. And so we would use a small needle, and it would be, through the belly with ultrasound guidance so that we can see everything appropriately. So now amniocentesis is usually done a little bit later in pregnancy. And so it's done anywhere between 16 and 20 weeks, sometimes even later than that. And so it's obtaining a sample of the fluid around the baby. The risk of miscarriage is also anywhere between 1 out of 300 to 500, but with an experienced, that's the national, general risk. But, I would definitely ask your doctor and your clinic what their reported risk is. With more experienced providers, it can be lower up, and it could be, kind of approaching 1 out of 1,000, which is a much lower risk of miscarriage. Just another quick picture. This is just amniocentesis, similar concept as that transabdominal CVS, but now we are, as the placenta has kind of shifted a little, as the baby and the pregnancy has the patient's gotten a little bit farther in pregnancy, we're now able to access the fluid around the baby, and that fluid around the baby holds skin cells from the baby, and believe it or not, it's actually the baby urine that the baby pees. It's just all sterile fluid that goes in and out of the baby. And so it has a nice sample of some of the cells of the baby in order for us to get the genetic testing and genes and chromosomes from the baby, genetic material. So this is a nice little summary slide. And I do have to say, I very commonly use counseling slides and genetic counseling materials from Greenwood Genetics Center. And so I just want to give credit where credit is due. So this just summarizes the maternal serum screening that we talked about, that first trimester screen, the second trimester, the quad screen, ultrasound. So the nuchal translucency is only done in this early gestational time period. Later on, we are doing an ultrasound around 20 weeks. We have non-invasive prenatal screening, which is NIPS or NIPT, cell-free DNA, which can be done at any time during the pregnancy, as long as it's after 10 weeks. So that's kind of the hard stop. We always do it only after 10 weeks. And then there is this last little bar is the diagnostic testing, which is CVS and amniocentesis. And so these top three are screening, and then this last one is diagnostic. So once we do amniocentesis or CVS, what do we do with that material? So now this kind of goes into the testing realm of things. And so I'll go into, the options of what tests are available. So we get a prenatal sample, it's given to the lab just like this. We either do a cell culture to grow the cells, and or we do a direct sample and we just extract the DNA from the cells, and we can do specific testing from that. The reason we grow the cells is, for one test, which is the karyotype of the chromosomal analysis, we need the cells to be in a specific phase of their life cycle. And so we have to just let them grow a little bit in order to achieve that. So this is an overview of, once we've done the CVS or amnio, what are the tests that are available to do? So the first test is a chromosome analysis or karyotype. And so this testing, I just have a few examples. That chromosome picture that I showed in the very beginning, this right here, that and this right here are a picture of a chromosome analysis. So we basically splay out all the chromosomes. It's a human being looking under a microscope. They've grown and cultured some cells. They've, are able to nicely identify, each chromosome 1, 2, 3, all the way down to sex chromosomes. And so this is just a nice picture of a typical female with XX, so it would be 46XX. And this takes a few, 10 to 14 days, upwards of, 2 weeks. So it does take some time to get these results back. This is just a male or a typical male fetus with an X46XY. And then this, just for example's sake, I put in trisomy 21 or Down syndrome just to show, a fetus that has that extra copy of 21. And then this, which is more, relates to more of our discussion, is a baby with monosomy X or Turner syndrome, where they're missing one copy of their X or Y chromosome. Okay, now looking at the next test, which is FISH. FISH is a really nice option for just a quick and dirty rule in or rule out test. You get your results back, usually within 72 hours, sometimes 48 hours, but usually about 72 hours. And so this is a nice little picture of fish testing. So we're putting a little probe on the chromosome. As you can see here, this is a chromosome and this is just a teeny dot, where we're putting a little flag on the chromosome and we put a dye on that and we see, does that little area light up? So it's really telling us, is the chromosome there or not? Or is there an extra copy of the chromosome? So if you look at the top portion of here, for each chromosome, usually, let's say we're looking at the X chromosome here. In this situation, it would be a normal, result where there are 2 copies of the X chromosome, and you can see the 2 dots that are flagged positive. This would be an example of someone with trisomy X syndrome or triple X syndrome, where there are 3 copies of the X chromosome. And so this is just a quick and dirty, the chromosome is either there or not. And this is a fish analysis showing where they've painted the whole X chromosome and it's showing XXY. And so there's 2 X chromosomes, as you can see, and 1 Y chromosome. It's just jumping into microarray. A microarray is basically looking at quantity of DNA. It is, it's not going to detect a balanced translocation where if there's 1 chromosome that's just flipped and 2 are switched, and there's still equal amount of total DNA, it's not going to see that switch if it's balanced. But if there's a small little piece of a chromosome that's missing, for example, if a piece of the Y chromosome is missing or a small piece of the X chromosome is missing, it would detect this. And so we look, on the microarray, the red dot means that an area, a quantity of the amount of DNA is missing in that region. And then the green dot means that there's too much or an extra copy of that DNA. Jumping into gene sequencing and whole exome sequencing, just some additional information. This, when we're getting down to the gene level, we have zoomed all the way into those chromosomes, we've unwound them, and now we're looking letter by letter to see if there's any spelling mistakes or spelling changes in those letters. And so if you look at gene sequencing, typically we do a panel if we think that there is maybe an increased risk of a skeletal dysplasia or something targeted where we want to look at a group of genetic conditions. And so we will look to see in that book of all of our genetic material, we'll focus on specific paragraphs, or let's say a page. If 1 page is a gene, we're reading through that page to see if there's any spelling mistakes. And so, if, for example, if you have a sentence that says the red apple fell from the old tree and you accidentally, the word apple is deleted, then it affects the meaning of that sentence and what that sentence is communicating. So jumping down to the most, kind of detailed test that the most comprehensive test we can do, which is whole exome sequencing. That would be reading through your baby's entire genome. And remember, this is all from an amniocentesis sample, or a sample from the baby that needle, get the sample, send it to the lab. And so we would be looking through all of the pages in the baby's book of DNA. When we say whole exome, we're looking at specific important paragraphs that are important for the baby's genes and function. And then whole genome, which we have not gotten there yet on a clinical basis, that just literally reads through every single letter in your baby's book of DNA. So this is a nice little summary also of, similar to the colored one that I showed up here. And I can provide this in handouts And so this just kind of summarizes that combined first trimester screen, the quad screen, CVS, and amniocentesis. And then one last little tidbit that I wanted to touch upon is, if you click rewind and you are in that group of individuals that are going through IVF, and this talk is, this subject is, could be a whole nother talk, but I just wanted to talk about pre-implantation genetic diagnosis or testing. And so, IVF, it involves extracting a woman's eggs, allowing the sperm to naturally fertilize the egg, which is shown here, or helping the sperm along and injecting the egg, with the sperm to get that to fertilize that way. And so once we've helped fertilization to occur, we have our little embryo with, multiple cell stage, and we just extract a few cells from that embryo, and we can do genetic testing on that. And so we are able to screen those embryos for chromosomal abnormalities, sex chromosomal variations, and such things. And so when you may hear some terminology called PGT, which means pre-implantation genetic testing. And there's PGTA, which means pre-implantation genetic testing looking for aneuploidy, which is a large, a whole chromosome is either extra or missing. Or there's a terminology that's called PGTM, which is looking for specific mutation or a specific variant in a gene. Okay, and that is it. I want to thank you so much for sitting and listening to my talk, and I hope that this talk answered some or most of your questions about prenatal genetic testing.